Hi everyone, my name is Keshini Lorena. I'm studying at KLMU, Kuala Lumpur Metropolitan University. I'm doing occupational therapy, third year, and here I'm going to present my case study for pediatric. Demography data. My patient name is R. He is 8 years old. His birthday is 24th of August 2008. He is a male and a Malay boy. He's staying at Kuala Lumpur and his dominant hand is right hand and the date of refer with me is on 4th October and the purpose of refer is for ADL retraining and his diagnosis is an autism. Okay, now the introduction part. What is autism? Autism spectrum disorder, ASD, and autism are both general terms for the group of complex disorder of the brain development. These disorders are characteristic in a various degree by difficulty in social interaction, verbal and non-verbal communication and repetition behavior. The sign and symptom spoken language, delayed speech development, for example, speaking less than 50 different words by the age of 2 or not speaking at all, frequently repetition of the said words and the prayers. Speech that sound very monotonous of the flat and preferring to communicate using single word being able to speak in sentence. For responding to others, not responding to their name being called. Reject initially by the parent or care, reacting unusual negatively when asked to do something or someone else. Interacting with others is one of the sign of symptoms. It's not being aware of other people's personal space or being unusual intolerant of people entering their own personal space. Avoid the eye contact, no eye contact at all. Whenever we call the name, they make don't know they won't bother us and they look somewhere else. Never look at our face, no eye contact at all, and not enjoying the situation that most children of their age like, such as the birthday parcel, and the behavior having repetitive movements such as flapping their hands, rocking back and the forth or flicking their fingers, and playing with toys in repetitions and unimaginative ways such as lining blocks up in order of the size or color rather than using them to build something. Having a strong like or dislike of certain foods based on the texture or color of food such as a taste, unusual sensory interest, for example, children with autism spectrum disorder may sniff toys, objects, or people inappropriately, preferring to have a similar routine or getting very upset if there are changes in their routine, and if there is any changes they will start to react unusual behavior like keep on crying, the OCD, everything will come out on that particular times. Okay, now the causes of the autisms. That is unknown single causes for autism spectrum disorder, but it is generally accepted it is caused by the abnormality in the brain structure and the function. Brain scans show difference in the shape and the structure of the brain in the children with autism compared in to the in neurological children's. Research do not know the exactly the causes of the autism, but are investigating a number of theory, including the links among the genetics and the medical problems. And many familiar that is appearance to be a pattern of autism or related disability. It also appears that some children are born with a unspecially autism, but researchers have not yet identified a single trigger that causes autism to develop. Other research are investigating the possible that under certain conditions, a cluster of unstable genes may interfere with the brain development or resulting in autism. Still, other research are investigating the problems during the pregnancy or delivering as well as in environment factors such as viral infections or metabolism imbalance or explore to chemical reactions. Occupational profile. The first is the personal history of my client. The patient name I already mentioned in front part is R and he's 8 years old. He stayed with his parents and his mother is a good care for him because she's the one who bring him to the center daily without missing any days or any sections. Even her mother is not feeling well or tired, but still she will bring his son to the center because of the care of on his son. Art likes to eat crunchies food so much. He loves to eat crunchies like Coco Crunch, Honey Stars, and Art don't like to share his food with others. Even like we act to take his food, he will like react hungry, emotional, and get it the food that we taken from his hand. Har likes to make friends, but he don't know how the way to make friends, so he go and just hug and scratch because of he wanted to make friends. And Har loved to hug and kiss him. Once we hug, he will calm down even in any angry emotional or any weird emotionals or something. Here, the second thing, the family history. In his family, have a father, a mother, his elder sister, and another brother, and he's the third son. The youngest is R, 8 years old. R staying with his family. And the social economy states, according to the patient's mother, the financial is the family problem of supporting their child because his dad is refused to paying the fees to the therapy center because his father feel that he's spending a much money on art. So it's like he don't want to pay anymore for the art. So it's get trouble to the art. He can't come to the center and school. So that its behavior getting worse. So that the staff from the physio center they give a special sponsor to pay the fees for the therapy and the school sessions. Medical history R has amnesia on his arm, legs, in the elbow, the knee joints. He scratched anti bleeding so that he taking some medicine cream to prevent his itchiness because when it get itchy he will start to scratch and it will be distract him from the play therapy on any activities that is performed in the center. And R does not take any medication. It's physically healthy enough and good. Social history. R do not like to make friends with others. R do not like to eat fruits or vegetables in pre-probate. And in the post-probate, R like to make friends with peers in the center and he like to eat crunchy foods. In education part, in the past, R studied in Permata, Korea. It's a government school that provide for the special kid. But within in 1 year, he had removed from the school because of his hyperactive behavior. It's like started to crash and distract others from during the lesson time. So just the Permata Konya just remove him from the school. So it's recently taking special education class at the school that's situated in therapy center by the occupational therapy. Okay, now the evaluation part. The subjective assessment R is very active in a home because he still keep on disturbing his brother and sisters. He won't listen to mother instructions or and his siblings, his sisters. He's just keep doing what he wish to do. When he get too active he or hungry, he will scratch and kick, bite or pinch whatever he like to do on that time until his mother got suffer for the pain that he make because he go and scratch his mother. That's the thing. And he needs special care to look after him because he can't sit at all at one place. He will keep on move around the surrounding that the environment that he stay. The objective assessment. The first part is the occupation performance area, the ADL activities of daily living and the instrumental activities of daily IIDL. So the assessment that I use for assess the ADL and IIDL is school function assessment. Okay, here is the school function assessment, the red copy that I do a snapshot. You can have a look. This is the continue part from the school function assessment to assess the ADL, manipulating with the movement and using materials. This is the third part for the continuous part for the school function assessment, assessing the ADL and IADLs. That is traveling, maintaining and changing the and recreation movements. And the fourth part for the assessing the ADL and IADL, cloth management, written work, up and down staircase, computer and equipment used. Y'all can have a look on it. The summary of school function assessment for the ADL and IADL all can't perform well his activity of daily living and the instrumental activities of daily living without any prompts because he have a weak muscle, so he still need some help to carry out his activities. This is the second part for the evaluation occupation performance components. In this, there is four: sensory, fine motor and gross motor, cognitive, and psychosocial. For the sensory, the assessment that I use is sensory profile. For the fine and gross motor, I use Peabody Development Motor Skills, and the cognitive school function assessment, and the psychosocial, I use the still same assessment, school function assessment. Okay, now the sensory component, sensory profile assessment. The sensory processing for auditory processing is R cannot work with the noise background. He will easily distract from the noise because he will cover his ears to avoid the noise, and also he will react depressed. He will like start to shout and scream and like jumping something. Visual sensory processing is R become frustrated when place him in a dark room. He will try to get out from the room, and he also become frustrated when trying to find things in is a messy background. He will try to just like escape from the room. Vestibular processing are seek for all kind of movement, and he will interfere with the daily routine, can't stay at one place. He will likes to rub unconsciously his chest during the class, and also he like moving around, and like we have to force him to sit and carry him to sit down without moving. If not, he will like start to scratch others, like keep moving. Tactile processing are express distress during grooming. He don't like if we comb his hair, brush his teeth, even if his hand dirty when we bring him to wash hand, he just run away. He don't like the water, and R likes, but he likes others to hug him. He feel comfort when people hug him. He will feel calm. Oral sensory processing. R likes to eat crunchy food so much. The most of time he will bring all the honey stars and cockroach for his dinner time. He will eat. That's only the thing. No any other rice or anything. Just the crunchy food with the water. That's all. And he shows strong preference for certain tastes. For proprioception processing, I take movement or risk things during play that that affect his personal safety. Whenever we put him on the monkey bar, he don't like to creep on the monkey bar, so that he will try to jump from the high place to the down. He will try something risk that affect his safety. Olfactory processing. Most of the time he will smell his things before use, or even his food also he will smell first before he eat. Whatever he take, he will first thing he will do is to smell first, then only the next steps. The summary of the sensory processings. Olfactory, he is a seeking behavior. For the tactile, he is a seeker behavior. For proprioception, seeking also. And oral, still seeking behavior. Auditory is avoider, he don't like any loud noise. For the vestibular, he's a seek. And for the last one is the visual, is still a seeker behavior because he don't like any dark room. He need a bright place to stay. Okay. Okay, this is the second part from the occupation performance component. This is fine and gross motor. The assessment that I use is Peabody Development Motor Skills. Peabody Developmental Motor Skill has 6 subsets to assess the client motor skills, but I use 4 subsets to measure my clients. The 4 sub-tests are stationary, locomotion, object manipulation, and grasping. Okay, the first domain under the assessment is stationary. This subset measures a child's ability to subset control of his or her body within its center of gravity and retain the equilibrium. So our raw score for stationary is 38 and his age for the stationary is 18 months. The second domain for the assessment, the locomotion. This subset measures a child's ability to move from one place to another. The actions measured including crawling, walking, running, hopping, and jumping forward. So our raw score for the locomotion is 152 and his age for locomotion is 45 months. The third domain for the assessment, objective manipulation. This subset measures a child's ability to manipulate the ball. Example of the action measure including catching, throwing, kicking. Because these skills are not apparent until a child has reached the age of 11 months. This subset is only given to children aged 12 months and older. Our raw score for the object manipulation is 25 and his age of object manipulation is 29 months. The fourth domain for the assessment is the grasping. This subset measures a child's ability to use his or her hand. It speaking with the ability to hold an object with one hand and progress up to the action involving the control use of the fingers of both hands. Our raw score for grasping is 46 and his age of grasping is 40 months. Okay, the third part for the occupation performance component, cognitive functioning. The assessment that I use is school function assessment. Okay, you can have a look. Function, communication, the memory and understanding. Summary of the cognitive part for the school function assessment is R need prompt to remind his performance, like his work, where to place his things, what to do next, and if not, he will just mingle around in the center without doing nothing and just place all the bags, his things just left in front of the door and just go away. So that we have to remind him to put the things, where to put the things, what to do next. So everything we have to keep on reminding him. The last part for this occupation performance component, psychosocial, the assessment that I use is school function assessment. You can have a look on the assessment. Is task, behavior, competitions, and the positive interactions. The summary of the psychosocial for the school function assessment is R. Recently, he trying to make friends with the certain kids in the center, but he don't know how to make friends. The way to make friends is like he don't know. And R do not like to listen for therapist instruction if they are not strict with him. And also therapy have to force him to do works he cannot cooperate with the therapist as well. Everything based on his emotion. If he's not in good mood, he won't do anything. If he's in good mood, then he will cooperate. And we have to be strict with him to do the works. The problem identifications. Occupation performance area, the activities of daily living is the first problem is unable to drink water from the cup. Okay, these are the things that I focus for the ADL as a problem. And the second part, occupation performance components for the sensory. The problem is poor frustration tolerance. And for the fine motor and gross motor, the problem is abnormal pencil grip. And for the cognitive, the problem is unable to understand the basic steps. The fourth, the psychosocial, the problem is avoid the group activity that provide in the center. The intervention, the treatment plan and goals, activities of daily living. Short-term goals is R will be able to have quarter glass cup of warm water with hand over hand in 1 month. Long-term goal R will be able to the set the table and prepare his drink of his choice independently with verbal prompt in 3 months. R will be able to lay out the tablecloth. R will be able to set up one glass for himself on the table for his mealtime. The second goal for the sensory is the short-term goal. R will be able to decrease his frustration during self-activities, swinging, creeping, upside down, standing on the ball. So these are the activities with partial physical form in 1 month. The long-term goals for the sensory R will be able to tolerate his frustration with therapists and the parents during self-activities with partial physical prompts in 3 months. The treatment goals for the fine motor and gross motor. Short-term goals R will be able to improve his hand strengthening so that he able to form a pencil grip from less mature static tripod to dynamic tripod in order a pencil in 1 month. Long-term goals R will be able to write in order his first name Rafi RAFI letter on his school book in 3 months. Treatment plan and goal for the cognitive. Short-term goals R will be able to understand of basic two-step of instructions with verbal prompt in 1 month. R will be able to put in his school bag inside the physio center cupboard independently once he enters the center. R will be able to put on his shoe in school rug independently before enter the center. The long-term goal R will be able to place back the materials and the tools is like for example the blocks, ball, books, color, pencil that he used in the center that belongs to the center that he used during the lesson time in 3 months within in verbal prompts. Treatment plan goals for psychosocials. The short-term goals are will be able to listen for at least 5 minutes in circle time in afternoon after lunch together with his school peers in 1 month. The long-term goal for the psychosocial treatment goals is R will be able to participate together in school activities that carry out daily by the therapist with independently within school parents in 3 months. Patient's asset. R's mother very support for her. R's mother willing to take him daily to the center even she tired or not feeling well. These are the patient assets. Model of practice, person, environment, and occupation PEO model. Through the PEO model, it has been indicated that Occupation performance result from the dynamic relationship between people, the occupation and the roles, and the environment in which they live, work, and play. It is a client-centered approach but equally emphasized in the place on the environment and the occupation where design intervention. PO PEO definition. Person, a dynamic and changing with the skill and ability to roll over the time. Environment, including the physical, social, cultural, and institutions, factors that influence occupation performance. Occupations include self-care, productivity, leisure. These are the things: P, person, environment, and occupations. Frame of reference, cognitive frame of reference, assessing the level of cognitive function and providing tasks appropriately to the level, aiming to describe the cognitive limitation caused by chronic illness, identifying the remaining function ability so that expectations of the clients are realistic. These are the reasons we are using cognitive frame of reference. Sensory integration frame of reference. This is provide to evaluate an intervention designed to identify, prevent, and remediate defects related to the child's sensory or perceptual skills, motor or parax skills, sensory sensitivities, and related patterns of function performance. These methods are used to achieve the overachieving goals of occupational therapy to improve the client's health and participation through the engagement in everyday activities of occupations. Rehabilitation frame of reference. Rehabilitation frame of reference is the independent is achieved through the adaptive device and rehabilitation frame of reference is focused to enable the greatest amount independence for the person in, for example, safely and in timing manner, engaging in meaningful leisure occupation, having the needed skills. The adaptive device is the wheelchair modification, ambulation aids, adaptation procedures, the splinter, the environment modifications that are the adaptive device that we use in rehabilitation frame of reference. Developmental frame of reference. The developmental frame of reference is based on the theory of human development in and across all skill areas. For example, is physical, cognitive, psychosocial, emotional, and psychosocial. The aim of developmental frame of reference is to identify the higher level motor, social, cognitive skill in which a client can engage and facilitate improve in function from the starting point. Humanistic frame of reference. In this frame of reference is changing occur through a relationship with other and it's seen as a vital of compliance with treatments and alternate to successful rehabilitations. Biomechanicals frame of reference. Biomechanicals looks into a client's physical capacity such as movement, muscle strength, and endurance. It's like more to for ideal works and ideal works. The treatment implementations. Problem 1, unable to drink water from the cup. The treatment that I given is training in ADL, drinking water from the cup, and the target behavior is child will be able to drink from a cup with assistance and overhand. And the frame of reference that I use to for this problem is rehabilitation frame of reference and biomechanical frame of reference. The condition and method that I use is skill should be have for the to the improve the child from drink water from the cup. His child is able to sit appropriately and child able to eye contact so that easy to give instruction and he can follow and child be able to follow simple one step directions and also should have fine motor skill needed to be complete tasks. And the method is the, the child able to hold the cups when present with a cup partially filled with liquid and given to the prompts hold the cup and the child will take the one sip and assist by the therapist without falling any drop of water and repeat the second step from the multiple sips acid by the therapist and generalize to various material and therapist setting and the prompts. The criteria is for 15 minutes. The rationale: if the child is able to take a drink by himself, it can less his mother burdens because drinking from a cup is still a basic activities daily living so that her mother can focus on other important things and child also can learn from basic things to more complex work. He can develop his performance from the basic steps. Okay, problem number 5. Avoid the group activities. The treatment that given is group play therapy and group fun activity. The target behavior is to improve and increase the interest in by joining the group activity. The frame of reference that I use is the rehabilitation, developmental and humanistics. The method and condition is child have to be sit in appropriately, establish eye contact, and the engagement in the isolated toy play, engage in social mimicking play, appropriately action demonstrations, and okay have to be participate in the circle time after the lunch together with parents. And the rationale is social group activity is an integrated part in our life. Activity become more important when the kids have more leisure time when they grow up every day. They participate in different kind of activity including self-care tasks, play tasks, leisure activity, provide the activity have specific goals where the participant is volunteer and can give happiness, meaningful activities, learning new things, and the relaxing themselves in increasing the social skill to others. The precaution for the problem is ensure the child is sit in proper positions and enjoying the activity that given and make sure that give a clear statement or instructions to make sure the child is understand what to do. The treatment plan. Problem number 2, poor frustration tolerance. Treatment 1 that given is sensory integration therapy for the problem. The target behavior is increase the frustration tolerance. The frame of reference that I use for this problem is sensory integration frame of reference. The condition and method: developing the coping strategies to deal with the frustration requirement time and practice. Teach the stop line with the deep breathing. Sample craft activity, tabletop activities. Use activities that work on the skills you are trying to build that are not exactly the same the skill itself. And the criteria is for 10 minutes. The rationale is frustration tolerance can be increased by simple changing the way you think about thinkings and others. Good frustration tolerance help. And the precaution is environment should be secure and free from the casual distractions. Problem-free abnormal pencil grip. The treatment can be given is positioning to prepare for gripping the pencil and writing. Target behavior is able to perform a proper pencil grips. The frame of reference is biomechanical and developmental and rehabilitation frame of reference that I use for this problem. The condition method is improve the muscle tone, improve the small muscle tone of the hand, working in the vertical positions to help stretching the whole arm, which is important foundation skill for writing, and heavy work activity developing arm muscles. For example, push up, crab walk, swinging in the trapeze, and the wheelbarrow walks. And these are the criteria for the 30 minutes. A rational expansive grip can be used to help the child activities mature, effective, correct pencil grasp. It is important to child to develop a mature, correct pencil grasp by the going through the developmental appropriative strategy of various pencil grasps. The precaution is environment should be secure and free from the casual distractions. Fourth problem is unable to understand the basics that the treatment is knowledging the child about the simple steps while modeling. The target behavior is able to understand simple instruction steps. The frame of reference that I use is for the this problem is developmental and the cognitive frame of reference. The condition and the method is create a simple activity to develop basic understand steps. Guide all the activities that do every day. Give reward when he complete any step even not good enough. Encourage to do works so that he can learn more steps. The criteria is for anytime and all the day you can practice these things. The rationale is by applying basic step understanding, he can perform his work independently so that he can learn new and more in studies. Understanding basic step will very meaningful because he can perform any other outdoor activities. The precaution is ensure the child understand the way of what they are doing, assist and supervise the child always, and ensure the instruction given are simple and clear. The home program is encourage the patient to do practice writing at the home and educate the caregiver about dressing step to teach the child, encourage the patient and the parents to do activity at like a wheelbarrow walk and push up to strengthen the hand so it will be easy to form a good pencil grip. Educated the caregiver about some method to calm the child when they get too active. The future plan is to continue the treatment as above that I've mentioned and reassess the patient if possible and also visit if possible to Sham Physio Center. The prognosis is the rehabilitation. Our own miss the appointment to come occupational therapy and R's mother able to follow the instruction that given to her after the treatment section. Medical R also will is starting newly to try say something new words. It's a good the last part in this case study presentation is the reference. Thank you for listening on my case study presentation.